I believe the most important aspects of the approach to device therapy is don't forget the drugs. Okay, that would be my key take-home message, is don't forget the drugs. I thought it was useful just to start this presentation with a description, certainly within training of the UK, is what constitutes a heart failure consultant, because it's a relatively new speciality within cardiology. Historically, we've undergone general cardiology training in the United Kingdom and then specialization for 2 years, plus often with fellowships and research into intervention, electrophysiology, grown-up congenital heart disease. More recently, again, developing into imaging, which you'll hear more about later. And I think over the last 5 to 8 years, we've now seen this emergent speciality of heart failure. In the UK, on the whole, if you do your subspecialty training in heart failure, you'll usually do it in conjunction with another area of cardiology subspecialty training, either devices, so it's heart failure and devices, or heart failure and imaging, and occasionally for preventative medicine and acute cardiac care, but mainly devices or imaging. And my area of interest is in heart failure and device therapy. So really, around this, we are primarily thinking about our approach to the utilization of CRT, biventricular pacing, ICDs, or a combination of that. But also, I think it comes into some aspects of brady pacing when that might be more appropriate, for example, than these devices, and occasionally other devices such as loop recorders. What I'm not discussing is advanced heart failure care in the context of assist devices. And I think that the key message here is that the implant of these complex devices is just one, albeit very important, but one aspect of the service for patients. And I would rather see this as the role of a heart failure specialist working with others to ensure that we optimize the appropriate use of device therapy for patients with heart failure. And I think this can be thought of in a number of different ways, from the setting up services such that patients can be appropriately identified, and ensuring that their medical management is optimized pre-device, careful case selection, which patients should be considered for a device and which device. It's essential, I believe, to counsel patients to the pros and cons of devices, some of the implications for in the UK driving, for example, ensure that they've got realistic expectations and informed consent, the device implant, the post-device care, which again, we've got some very nice data showing the ability to optimize drugs further, particularly after CRT, afterwards, programming, troubleshooting. And again, if you're implanting an ICD, I think it's essential that prior to implanting that is to initiate what's going to happen at the end of life. It doesn't, there will be, patients will not be immortal, they will die at some time, and we need to think about early on how we're going to come to approach that. And certainly what we've set up in our locality is the multidisciplinary team approach to this again, and I think this really offers comprehensive expertise for patients at different aspects of their journey. And we work very closely in conjunction with electrophysiologists, working with heart failure consultants, imaging, and occasionally revascularization as well for the patients. But that's in conjunction with other aspects of the service, heart failure nurse specialists, arrhythmia nurses, and we have physiologists that are very much involved in the follow-up of the device patients and some of the optimization of the programming algorithms. And what works very well here is that we have a lot to learn from each other, and we all feed back very well and hopefully take on board experience and knowledge and expertise from each other in this to provide a comprehensive service. And I think there's a lot of mutual respect in that. I think that's fundamental to these services. So think about patient identification. Bivent CRT primary prevention ICD for LV systolic dysfunction, so not thinking about inherited high-risk cardiomyopathies. The majority of patients are identified via heart failure services, I think, here. Certainly in our institution, they'll be fed in through the heart failure services. And what we've tried to do with that, and Geraint has alluded to that as well, is we've tried to establish a service whereby a patient is seen by the most appropriate individual at that time, and there are no barriers to get the patient there, or trying to diminish the barriers, I should say, to get the patient there. We link very closely with the post-MI services for re-evaluation of LV function after appropriate period of time for drug therapy to hopefully see beneficial reverse remodeling, something I'll come back to. And I think a major component of what we do as an MDT is to provide education around what devices have to offer for our colleagues in elderly care. So we have very much established elderly care physicians in the United Kingdom into the community services and to colleagues. And I think one of the things that is important is don't forget to do an ECG. It's all too easy now to do repeated echocardiograms and not see patients that have gone through several years of the heart failure journey without a repeat ECG and missing left bundle branch block, for example. So the medical management pre-device, this will of course vary as to how patients present. If a patient presents with a resuscitated out-of-hospital cardiac arrest, then the time to optimize drugs prior to making a decision of a device implant is much shorter, of course. However, one shouldn't forget the fact we need to optimize the drugs after the device implant. But for primary prevention ICDs, that is after a myocardial infarction or after presentation with a dilated cardiomyopathy, or for biventricular pacemakers, the decision should be based after an intensive period of appropriate medical optimization. And of course, it's hard to give an absolute definition of what that period of optimization should be, because it will very much depend on how a patient's doing. If a patient's responding well, then I would tend to defer making that decision for a longer period of time than if they're going downhill, in which case a CRT may be very appropriate to change that patient's journey. And this optimization really follows on from what Geraint said, that it's undertaken by a group of healthcare professionals working seamlessly together. We link very closely with post-MI care, and again with the advent of primary angioplasty, and even for patients presented with non-ST segment elevation myocardial infarction, in our institution the majority will have their procedure within 24 hours, and if not 48 hours. There's a major pressure from the health economics, from beds in hospital, to discharge patients early. And that's all well and good for patients that have got relatively preserved left ventricular function with a small infarct. But those patients that have a large infarct, I think the worst thing we can do for those patients is discharge them on day 2 or day 3, where we haven't as yet optimized their drugs and miss this great opportunity to deliver something that can really change their medical course. Drugs may actually negate the need for the device. Commonly, we see patients with beneficial reverse remodeling, improvement to ejection fractions above 35% after a sizable myocardial infarction or after presentation with a cardiomyopathy, and certainly we've got no data on which to be implanting drugs above that. Implanting devices, we're not implanting drugs yet, luckily, above 35%. And the major prognostic benefit is gained from the optimal combinations of drug therapy, and of course there's an added benefit of devices in appropriately selected patients. And what's fundamental for patients to realise here, I think, is that the device isn't a substitute for good drug therapy, because there's often a misconception that that is the case. Our cases, we have a device MDT, again, working, it's around about an hour a week, where we have one of our heart failure specialists, electrophysiologists, and one of our physiologists who would bring identified problems around patients with devices or concerns, and we'd discuss all of the case and patients and document outcome and plan whether or not a patient is a suitable candidate for a device. Many of these are black and white, but it's still a very healthy way of approaching it, particularly when we're talking about implanting expensive devices for the healthcare system. But we make key decisions here about the appropriate use of CRT pacemakers as opposed to defibrillators or vice versa, whether a Brady device versus a CRT is most appropriate. And we again are regulated by NICE requirements, which affects the reimbursement for us implanting these devices. I think there are crucial things that you need to plan better, or we can all plan better. For example, box changes. If a patient's had an ICD implanted in their mid to late 70s and they're now in their early to mid 80s and they haven't had any recent treatments from the device, we need to really think carefully whether that is the right approach to re-implant an ICD, a box change. Is that the right thing? Have the patients developed lots of comorbidities likely to impact on their life expectancy? Do we need to upgrade pacemakers or ICDs to CRT? Has heart failure progressed? Has conducting system disease progressed? And identify lead-related issues early on. The key is to avoid surprises on the day. That is unpleasant for all involved in cases, not only you as the doctor involved with it, but also for patients. And cancelling patients is really an unhealthy thing to do. We plan aspects of upgrades in particular, think carefully about the route of access, anticoagulation, antiplatelets for post-MI patients, thinking about how we can refine those to diminish complications, evaluation of renal function, and look at comorbidity, because we use nurse-led conscious sedation for the implant of our devices. So these are our NICE guidelines, and I won't go into them in great detail. Safe to say that we are entitled to consider defibrillators for patients who have already had a serious ventricular arrhythmia, either a cardiac arrest or have had syncope or hemodynamic compromise associated with it. In terms of thinking about primary prevention devices or CRT, so this is thinking about patients with an ejection fraction less than 35%, then if you're in NYHA class 4, the recommendations are not to implant a defibrillator, in that the life expectancy of that patient is likely to be less than a year. I think there are some circumstances one might reconsider that if you're anticipating a likely benefit from the CRT, or if you have a patient who may be eligible for transplantation, for example, which is a small number again in the UK. The defibrillator side is really ejection fraction less than 35%, NYHA class 1 to 3, and then the CRT comes in very much in keeping with the evidence base out there that left bundle branch block really seems to benefit greatest from the CRT. And if you've got non-left bundle branch block, QRS prolongation, really for patients with a QRS greater than 150, particularly if you've got prolonged PR interval. So it fits with the European Society guidelines, but we would be challenged if we were to be implanted large number of cases outside of these guidelines. So all of our patients see a consultant with device interest, which might be an electrophysiologist, but very commonly a heart failure specialist. They're seen and counselled by a specialist nurse, going through the case again, and we carefully plan things, for example, in trying to ensure that patients on warfarin have INRs 2 to 3, so not too high when we're doing it on anticoagulation, identify other potential issues, diabetes management, and things that might impact on conscious sedation, and also initiate end-of-life discussions, and I think that is very important. One of the benefits of working cohesively with a group is that I think we've streamlined our service, learned from each other, and have taken on board new data as it's come through. So we've gone from having probably concerns about conscious sedation, where initially 10 years ago probably with anaesthetists present, to nurse-led conscious sedation, adoption of new data, so we will do our devices on full anticoagulation, day case procedures. We started doing pacemakers as day case procedures, then ICDs, and more recently biventricular devices as day cases, and again bringing in the new data on board, having initially done routine defibrillation testing, embrace new data as it comes out, and try and refine the service to the benefit of patients and the smooth running. Post-device care, again, we have our specialist nurses are involved with this, as well as reviewing the wound and making sure the patient's making good recovery. There's a great opportunity, certainly with CRT, to optimize drugs further. So a down titration of often high-dose loop diuretics or combination of diuretics, and thereby permitting an increase in beta blockers, an increase in ACE inhibitors that might have been challenged because of low blood pressure, for example, before, due to the benefits of the device. So we should think about, can we improve things further? Arrhythmia management, and this is where working together with heart failure doctors and electrophysiologists, I think, offers a huge, huge benefit. The common problems of management of atrial fibrillation in these patients, ventricular arrhythmias, it's great to be able to pick brains of experts. And programming. And again, if problems occur down the line for patients, don't forget to reevaluate drugs. So if a patient has a shock, or if there's a change in symptoms that come through, they may not be routinely followed up in our cardiology follow-up clinics. They will have device follow-up, but if we think we've optimized them, we like to leave the door open them to come back when they need to be seen. And I was just going to share some data that we've published again from the UK Primary Care Research Database. So this is a very interesting data set we have available to 4 million patients in the UK are tracked from this database. There are limitations of the data, but this was a study that is involved with looking at the use of beta blockers, and really what it showed is, having had a first ever prescription for a beta blocker, if you look at whether patients are continuing it for cardiovascular disease, it's pretty dismal outcomes. So people are stopping drugs that you spend a long time getting them on board. So we see that a third of patients here stop them at a year, and over 50% at 3 years. So if patients start to deteriorate, always think about, has someone tinkered inappropriately with their drugs? And I use the message to people who want to stop people's beta blockers that actually, if this was a patient who had cancer and was on chemotherapy, would you tinker with it? And the answer is generally no. And actually, you're doing more harm to the patients here than stopping someone's chemotherapy for breast cancer. The final thing to say is that I think we all have a responsibility to think of the financial implications to the health service of what we're doing. So, for example, in the UK, certainly a biventricular defibrillator is around 4 to 5 times the costs of a pacemaker. And we need to think who will gain the greatest from that. We need to think about the benefits of an ICD, particularly driven by age, that there's very little data for patients above 75. NICE can't make these recommendations. And really, we have to be responsible to ensure we get a greater benefit for all of our patients. So, thank you very much.